Hello, my name is Lynn Yee, and I'm a maternal fetal medicine physician with the Women's ID program. In this brief video, we're going to talk about antenatal care of pregnant people living with HIV. First, a bit about the epidemiology of perinatal transmission. It's important to know that of 100 infants born to people living with HIV who breastfeed and do not have any interventions to prevent transmission, approximately 75 infants will not acquire HIV, whereas 25 will. Approximately 30% of transmissions occur in utero, 50% are during labor and delivery, and 20% are during breastfeeding. This means that even with interventions conducted or initiated during the intrapartum setting, so you still have the great potential to be able to reduce the likelihood of transmission. What are some of those risk factors for transmission? Well, there are maternal, obstetric, and infant risk factors. Among the maternal risk factors include elevated viral load, a low CD4 count, co-infections such as sexually transmitted infections or opportunistic infections, IV drug use, and then lack of antiretroviral therapy. Obstetric factors include prolonged rupture of membranes, chorioamnionitis, a vaginal delivery in the setting of elevated viral load, and invasive obstetric procedures that could increase the contact of maternal blood for the fetus. And then finally, infant factors include prematurity and low birth weight. This is a roadmap to the elimination of maternal to child transmission, which I will briefly review. As you've already heard about in videos about safer conception and about preconception, it's important to note that in the preconception period, key steps to eliminating maternal to child transmission include optimizing antiretroviral therapy and use of contraception in order to help individuals plan their pregnancies for when they're most desired and at their healthiest possible state. In the first trimester, key elements include addressing optimal ARV choices, addressing reproductive choice, obtaining all baseline prenatal and HIV labs, and crucially supporting early pregnancy symptoms such as pregnancy-induced nausea and vomiting in order to promote adherence to antiretroviral therapy. In the second and third trimester, increasing antiretroviral dosing may be needed, and maintaining the regimen is crucial. We will monitor viral load and for toxicity and promote adherence through psychosocial support and wraparound services. In addition, delivery planning and postpartum planning happen in the third trimester. At the delivery admission, we will plan for route of delivery and administer intrapartum zidovudine. We'll continue antiretroviral therapy during the hospitalization. And there's some alteration of labor and delivery practices in order to optimize the chances of a successful prevention of maternal to child transmission. In addition, as you'll hear in talks from Dr. Miller, there are immediate neonatal care practices and a neonatal medication plan in order to prevent transmission. And then finally, in the postpartum and interconceptional period, optimizing antiretroviral therapy, developing a long-term follow-up plan, and adapting and having a neonatal care plan and contraception are all parts of preventing transmission and maintaining health for the mother. So why are we so interested in viral load surveillance? As you know, viral suppression is key to maintaining both a healthy mother as well as preventing transmission to the neonate. In this landmark paper by Dr. Garcia in the New England Journal of Medicine in 1999, Dr. Garcia's team demonstrated that maternal levels of plasma HIV was directly associated with the risk of perinatal transmission, and that particularly with viral load levels over 10,000 and over 50,000 copies per milliliter, the risk of transmission was doubled and quadrupled. So antiretroviral therapy is key to promoting health of the pregnant patient. We know that the current guidelines state that all adults need treatment for HIV. Treatment with antiretroviral therapy improves the health of pregnant people. It also decreases the risk of transmission of HIV to the infant. So it's a key element of care for both the mother and the fetus. We also know that the guidelines recommend that pregnant people with HIV receive treatment as soon as possible. So as soon as they initiate prenatal care and HIV is recognized, even if genotype is not back yet. Adherence support and counseling cannot be overemphasized. These are crucial in order to be able to get to the goal, which is an undetectable viral load. Briefly, regarding antiretroviral therapy, we'll comment on how the different drugs work, and you'll hear more from this from our pharmacy colleagues. In order for the HIV virus to multiply, multiple steps need to occur. The virus has to attach to receptors on the CD4 cell. The HIV RNA needs to be reverse transcribed to the double-stranded DNA. That DNA needs to be integrated into the CD4 cell's DNA, and then HIV-specific proteins need to be made and assembled into new infectious particles. Antiretroviral drugs target each of these steps and can be used or are used in concert to prevent replication of the HIV virus. There are 4 classes of antiretroviral medications that are used to block entry of the HIV virus into the CD4 cell. And these include entry inhibitors or fusion inhibitors, NRTIs or NNRTIs, which are known as nukes and non-nukes, integrase strand transfer inhibitors known as INSTIs, and protease inhibitors. Antiretroviral therapy guidelines, or antiretroviral therapy regimens, are typically 3 drug regimens that are 2 NRTIs plus a preferred INSTI or a PI. Considerations that go into choosing a regimen include a number of factors. These include dosing and pregnancy pharmacology, side effects and the risk of toxicity, tolerability in pregnancy, and then prior regimens or known resistance issues for that patient. The perinatal guidelines, which I'll touch on in the next slide, are based on issues such as ease of use, lack of teratogenicity, lack of clinically significant adverse effects, PK data to guide dosing, acceptable toxicity, and optimal efficacy. This is a bit of a snapshot from the perinatal guidelines with the website listed there. It's clinicalinfo.hiv.gov, and then search for the perinatal guidelines. This is also where you can find adult guidelines and guidelines for adolescents and children. Within this document, which is an incredibly useful source of all information about the latest in guidelines for caring for pregnant people with HIV, you'll find the preferred ART regimens. I won't go through these in detail, but you can see here that the preferred dual NRTI backbones include abacavir 3-TC or tenofovir emtricitabine. There are also preferred integrase strand transfer inhibitor regimens that include those seen here. In addition, there are preferred PI regimens with atazanavir or darunavir that would be additional options for treatment. And then you can consult the perinatal guidelines website for more information about some of the alternate regimens. Next, we'll speak about antenatal care. So what happens at the first visit? In addition to counseling about all of these issues related to prevention of perinatal transmission, providing supportive care, and providing in-depth options counseling, we're also going to provide or conduct labs at the first visit. These include all the prenatal labs, typical labs such as type and screen, RPR, rubella, gonorrhea, chlamydia, varicella, measles, and others, as well as a pap smear, hepatitis panel, baseline CMV and toxoplasmosis titers, T-cell monitoring panel, viral load, a genotype if it's unknown and if the patient is viremic, but don't wait for the genotype to return in order to start antiretroviral therapy, quantiferon, G6PD, and then baseline chemistry and CBC. Following that first visit and initiation of medications, we'll conduct regular HIV viral load monitoring. This is typically done monthly for high-risk patients, which includes those who have a late presentation to care, who have had adherence challenges, or who have AIDS, or if the patient is not yet virally suppressed. Once a patient is virally suppressed and adherent, in particular, if she's always been suppressed, these labs can be spaced out to every 8 to 10 weeks. And we want a final viral load at about 37 to 38 weeks in order to be able to plan for labor and delivery. We also want to do surveillance for antiretroviral toxicity. Although most of the drugs in our current armamentarium have relatively little toxicity, we still do surveillance with complete blood counts and chemistries at baseline and at the first visit after medication initiation. And then labs can be spaced out to about every 8+ weeks, 8 to 10 weeks, unless there's signs or symptoms of toxicity or you're monitoring for specific labs. Labs may need to be done more often if a patient is on opportunistic infection prophylaxis that may have potential side effects. Additional aspects of antenatal surveillance include doing toxo and CMV, IgG, and IgM monthly if a patient has a CD4 count less than 200. But if her CD4 count is over 200, this does not need to be repeated monthly, or actually at all during pregnancy. In addition, for CD4 count surveillance, we'll conduct this every 4 to 6 months if the CD4 count is normal or high. But if it's less than 200 and we're awaiting a rise, we'll conduct this approximately every 8 to 12 weeks. With routine 3rd trimester labs, we'll do a hepatitis C test if risk factors warrant. And then with GBS testing, we may do the gonorrhea and chlamydia testing again. And then finally, vaccines are a key part of antenatal care. These include flu, Tdap, now COVID testing or COVID vaccines, hepatitis B, hepatitis A, and then Pneumovax if it's not already given. Lastly, I'll just touch on some overarching principles about antenatal care. Key to optimizing antenatal care is optimizing the antiretroviral regimen. This includes the timing of the regimen, the pill burden and adherence tools such as pill boxes, monitoring for side effects, and looking for medication interactions. Medication interactions can be especially important to keep an eye out for in pregnant patients who are more likely to need antiemetics or to be on supplements such as iron or have medications for issues such as GERD. In addition, monitoring for comorbidities, including sexually transmitted infections, is crucial. We'll provide opportunistic infection prophylaxis as needed. And then an important element of antenatal care is planning for labor and delivery, such as discussing the birth plan, an infant feeding plan, and high versus low risk neonatal protocol. And then finally, supportive care, including wraparound services with social work, care managers, psychology, and other experts, is really essential to promoting a healthy pregnancy. Thank you. And next we'll touch in a moment on intrapartum care.